Back in 2016, we did a special series on opioids here at Healthcare Triage. And now, with continued support from the National Institute of Healthcare Management, we're going to spend the next 4 episodes augmenting and updating that series. In this first episode, we'll talk about the effect of the crisis on the healthcare system and other systems, and how new regulations are affecting patients, where we're at with research and treatment, and where we need to keep pushing. All of that is the topic of this week's Healthcare Triage. A recent report from the Society of Actuaries, or SOA, estimates that the economic cost of the opioid epidemic from 2015 to 2018 was over $631 billion. Approximately $205 billion of that was healthcare spending for those with opioid use disorder, for infants exposed to opioids in utero, and for related health issues of other family members of opioid users. The effects of the epidemic continued to be felt far and wide, beyond the money. As overdose deaths rise, so do calls to first responders. Access to and use of naloxone, a medication that quickly counters the effects of an opioid overdose, has quickly expanded among first responders, including non-paramedic first responders like police officers and firefighters. Naloxone administrations during emergency medical service events increased more than 75% between 2012 and 2016. Data also suggests that the frequency of multiple naloxone administrations to a patient by EMS providers, a potential indicator of opioid potency, is increasing in some regions. In 2016, New Orleans reported more overdose deaths than murders for the first time in their history. Of the fatal overdoses reported, 78% were opioid-related, and EMS calls for opioid misuse rose from over 600 to almost 800 between 2015 and 2016. It's not just the healthcare system that's strained by the crisis, though. The criminal justice system accounts for about $39 billion of the economic cost we mentioned before. This includes things like police, court proceedings, and correctional facilities. The foster care system is also feeling the brunt while trying to provide temporary homes to children of addicted parents. Their resources in terms of funding, social workers, and families are stretched thin, and those problems are further compounded by the need to place children who require extra care and attention following exposure to opiates in utero. According to the CDC, neonatal abstinence syndrome increased from 1.5 per thousand births in 2004 to 8 per thousand births in 2014. Government-funded child and family assistance and education programs also account for approximately $39 billion of the economic price tag we've discussed. In an effort to address the opioid crisis, major attention has turned to prescriptions in recent years. Opioid prescriptions per capita decreased between 2010 and 2015, but remained approximately 3 times higher than in 1999. In 2015, over 33,000 drug overdose deaths were opioid-related, and close to half of those involved a prescription opioid. Given these numbers, it's hard to argue against initiatives that aim to regulate and reduce opioid prescriptions. However, attempts thus far might be exacerbating the problem in unintended ways. In March of 2016, the CDC released guidelines for prescribing opioids for chronic pain treatment outside of cancer, palliative, or end-of-life care. Since their release, patient advocates, pain doctors, and others have stated concerns that the inappropriate use of the guidelines could negatively impact patients in need of pain management. For example, the CDC guidelines advise against dosages over 90 morphine milligram equivalents per day, but this is meant for patients just starting an opioid prescription for short-term pain, not for patients who've been taking opioids regularly for chronic pain. For those patients, sudden tapering or discontinuation of long-term opioid prescriptions can result in extreme withdrawal, pushing some to illicit opioids like fentanyl, and pushing others as far as attempting suicide. Though deaths resulting from prescription opioid overdoses have slowed, deaths attributed to illicit opioids have increased alarmingly. While a 2019 systematic review reports a lack of research on how and to what extent current laws are associated with opioid deaths, research on that connection is sorely needed. Chronic pain patients rely on strictly controlled doses to help them function despite their chronic pain, which is a different scenario than life-disrupting addiction. While data suggest effective non-opioid options for managing chronic pain, there's still not enough research to determine the full picture. And in any case, we just can't turn off the use of those drugs overnight, at least not safely. According to a 2019 review, more than half of the states in the U.S. have laws constraining opioid use for acute pain, most of which were enacted after the 2016 CDC guidelines were introduced. But despite their designation for acute pain, patients with cancer or chronic pain issues are often affected. Physicians are having to balance their patients' well-being with concern over legal repercussions, and insurance companies and pharmacies are using the CDC guidelines to impose strict prescription limits. These strict limits ignore the fact that the guidelines do not suggest an automatic cutoff of 90 morphine milligram equivalents per day, but rather suggest that physicians use caution and appropriate justification when prescribing above that limit. And as many physicians are pointing out, these are guidelines, not mandates. A March 2019 letter to the CDC, signed by numerous medical experts, called for clarification, in no uncertain terms, that these guidelines do not mandate involuntary tapering or sudden discontinuation of opioids in chronic pain patients, and that the plan of action for these patients be determined by a physician who's aware of the nuances of each patient's situation. The letter was accompanied by hundreds of testimonials from pain patients struggling with the after effects of new regulations. Medical experts certainly aren't against regulations aiming to stem the tide of the opioid crisis, but those regulations should be ethical and effective. A 2019 ethics evaluation of regulatory interventions for opioid prescribing did not deem it ethical to enact strict prescribing limits that do not consider situational and patient characteristics. Regulatory authorities seem to be listening. In April of 2019, the CDC director issued the clarification requested by medical experts. And in mid-2019, the authors of the CDC guidelines released a paper addressing inappropriate implementation of the guidelines. The FDA also jumped in last year, requiring that warning labels include information about the risks of rapid tapering. We'll need studies, of course, to understand how all of this plays into the larger picture of licit and illicit opioid overdoses and deaths. As we mentioned in our first opioid series, the best way to treat addiction is to prevent it, which is one reason why understanding the effects of opioid prescription practices and the effects of changing regulations is so important. In the meantime, what new efforts are we making to address the crisis, and what more do we need to do? There are ongoing efforts to improve treatments for opioid misuse and addiction, including the NIH HEAL initiative, which was established in 2018 and aims to fund scientific research on lasting solutions to the crisis. As part of that initiative, the Justice Community Opioid Innovation Network, or JCOIN, was formed in 2019 to support nationwide research on improving opioid-related treatment within the criminal justice system. Research is now being conducted to determine treatment gaps and effective strategies in criminal justice settings such as jails, drug courts, and probation and parole. The U.S. Department of Health and Human Services has also allocated funds to provide training and medication to EMS personnel, to support services for pregnant and postpartum women and children affected by opioid use disorder, and to expand access to medication and to long-term recovery support. A 2019 report from the National Science and Technology Council reported on the state of the science in relation to the opioid crisis, as well as current research gaps. Research continues to support the effectiveness of medicines such as methadone, buprenorphine, and extended-release naltrexone. It also emphasizes the importance of individualized treatment versus one-size-fits-all, with that treatment including medicine, as well as psychosocial supports such as Narcotics Anonymous and cognitive behavioral therapy. Recent data also tell us that individuals receiving only short-term treatment are at high risk of relapse. Long-term, evidence-based care is critical. The report also nods to research in neuroscience that sheds light on opioid-induced molecular changes and altered addiction pathways in the brain. Data like these may play a big role in shaping attitudes surrounding addiction, namely that addiction is not a moral failure, but a behavioral result of physical changes in the brain. Lastly, the report highlights gaps in the research that still need to be assessed. We need longer-term studies that we can generalize to more populations, such as patients in rural settings or those with mental and physical comorbidities. We need more research on the specific needs of vulnerable populations, including pregnant and postpartum women. Research on how to effectively implement treatment in non-specialty settings will also be critical moving forward. There are contributors to the opioid epidemic outside of prescription practices. Drug overdose deaths are called deaths of despair, and those deaths are a big reason that U.S. life expectancy actually began to decrease in 2014. More on all of that in next week's Healthcare Triage. Hey, did you enjoy this episode? You might enjoy our whole past series on opioid use and misuse. Also helps if you like and subscribe down below, and consider going to patreon.com/healthcaretriage, where you can help support the show, make it bigger and better. We'd like to especially thank our research associates, Joe Sevitz, Joshua Gister, and James Glasgow, and of course, our Surgeon Admiral Sam.